we're very excited to have Dr. Brad Spellberg, who many of you will know already of. He is the Chief Medical Officer of the LA County University of Southern California Medical Center. He's written award-winning books. He's done a bunch of things which make a very, very long and impressive CV, but has been very influential, certainly around these parts, in two regards. One is the shortening the duration of antibiotic therapy, and the other is this really exciting reevaluation, I guess, of the evidence in terms of oral antibiotics for some severe infections, which dogma has taught required intravenous therapy throughout. So we're delighted to have him. It is just gone 6 a.m. at his time, so we're incredibly appreciative for him for joining us, before waking up so early and getting online just to talk to us. We're looking forward to hearing from you, Brad, and thank you very much again for your time. Take it away.
Well, thank you so much for the invite, Jeremy. I'm really delighted to be here. So exactly what we're going to do today is ask the question, is it reasonable to consider oral antibiotics to treat 3 diseases for which historically the medical community has said, don't even think about it. It's the third rail. It's totally unacceptable. It has to be IV only. I'm going to spend a lot of time talking about data, but I want to spend the first 5 to 10 minutes talking about a philosophical framework within which to interpret the data. So there are both pro and con arguments for oral therapy for these 3 diseases. Now, I am not known for my subtlety. I'm autosomal recessive for the subtlety genes. If you drew my blood and did a subtlety enzymatic activity, the result would be below the limit of detection. So we'll see if you can discern from my tone of voice and maybe facial expressions which side of this debate I'm on. There are 3 points that underline the pro argument that it is reasonable to consider oral therapy for these 3 diseases. First, in contrast to older antibiotics, and I'll show you some of these data, modern oral antibiotics actually do achieve adequate levels in blood and bone to exceed the target MICs to inhibit microbial growth. Phrased another way, the bacteria don't actually know the route of administration you use to administer the antibiotic to the patient. It's not like there's bacteria sitting in the bone going, well, normally if there was this much antibiotic around, I'd stop growing, but you chose to give it orally, so I refuse to stop growing. They're smart, but they're not that smart. Second, we know from numerous prospective studies, including randomized controlled trials, that intravenous therapy is intrinsically less safe. We tend to underestimate the frequency and severity of adverse events related to that catheter. It turns out hominids did not evolve with large plastic tubing in our central veins for 6 weeks at a time. So that in prospective studies, anywhere between 10 and up to 50% of patients, depending on the study you look at, develop deep vein thromboses, line infections. They have fractured lines. The line migrates. They require surgery or IR to retrieve centrovenous stenosis, bleeding at the site. These are significant adverse events that do not occur to patients you put on oral therapy, and we underestimate this harm. And then third, as we'll go through, there are now extensive randomized controlled trial data showing that oral transitional therapy is as effective as IV-only therapy for these 3 diseases. And importantly, there has never been a single prospective controlled study ever showing that IV-only therapy is superior for any of these 3 diseases. And frankly, collectively, these 3 fundamental points feel pretty compelling to me. You know, this is a pretty robust set of arguments in favor of pro. But they are counterbalanced by 2 principal con arguments. And these are, if you boil it down, these are the 2 con arguments that people hit me back with. Any data you show me supporting that oral therapy works are imperfect. And if you cannot show me perfect data that extrapolate to every organism at every body site for every patient in every country, on every planet, in every solar system in the universe, then we have to keep doing what we've always done. That's the historical argument. Historical practice must continue in the absence of perfection, overturning the old practice. That's the argument. These are the two principles that people hit me back with. Here's my problem. Now, I'm going to tell you the story about Benjamin Rush, who was a famous physician in the United States. And I tell you this story, the point of this story is, no matter how smart you may be, no matter how influential you may be, famous or eminent you may be, you can always be wrong. And that's a lesson I think some of the folks who put out guidelines in our field have forgotten. So let's remind ourselves who Benjamin Rush was. In the United States, he was sort of a major force culturally during the colonial era. He actually was a signer of the Declaration of Independence. He was the Surgeon General of the Continental Army under George Washington, reported directly to Washington. He was beyond a physician, a leader of the American scientific enlightenment, believed in empiricism. Now, I don't think he did experiments particularly effectively, as we'll see, but he believed in testing things to see if practice should change. And he was certainly the most famous physician in the 18th and early 19th centuries in the United States, by far. There's a medical school named after this guy. He was also a believer in bloodletting and probably killed some folks during a malaria outbreak in the Washington, D.C. area. But more importantly, for our purposes today, he was the inventor of something called Rush's Thunderbolts. Now, what were Rush's Thunderbolts? It's very important that you understand that I am not making this up, because you're going to say to yourself, there's no way this is real. You're totally making this up. But if you wish to stave off comahood, because I tend to induce coma in my listeners, you could ask Dr. Google while you're in front of your terminal right now about Rush's Thunderbolts, and you'll find out that I am not, in fact, making this up. What were Rush's Thunderbolts? Well, Benjamin Rush patented a special formulation cure-all and sold a ton of this stuff, made a huge amount of money selling this stuff as a cure-all for whatever disease ailed you. So if you had a fever, you needed a Rush's Thunderbolt. Oh, you've got abdominal pain. Well, I think you need some Rush's Thunderbolts. Oh, you fell and broke your arm. What you really need is a Rush's Thunderbolt. They were used for everything. Now, what were the ingredients in Rush's Thunderbolts? Well, they principally worked by inducing voluminous diarrhea to expunge the evil humors from your body. So the principal ingredients were, we'll get to that next slide. I forgot to mention, this stuff was so widely used that Lewis and Clark, the famous expedition all the way out west and back to survey the United States, this was the principal thing they used to treat their colleagues. This was the only medicine they really brought along with them. They bought several hundred doses of Rush's Thunderbolts, and in their diaries, in their journals, they actually document administering them to their colleagues, successfully thereby inducing voluminous diarrhea. And as I was starting to mention, it was the principal ingredient that induced the voluminous diarrhea was an extract of the jalap plant, whatever that is. But for our purposes today, perhaps more importantly, the second principal ingredient in Rush's Thunderbolts was mercury. And this is where this story starts to become outright sad. Doctors in the United States continued to actively poison people, overtly harming them for more than 150 years because Dr. Rush told them to. This is a photograph of a pharmacy compounding manual published in 1946. This is in the penicillin era, people, describing how doctors could order pharmacists to mix together mercury and jalap extract in what was essentially a modern version of a Rush's Thunderbolt 150 years later. Now, there are people who have said to me, well, that's asking Dr. Rush to be quite forward-thinking. How was he supposed to know the stuff was poisonous and he was harming people? And if that's what you're thinking, let me introduce you to Mr. William Cobbett, who was a British expatriate living in the United States at the time. He was not a scientist or a physician, but he had common sense, and clearly recognized that poisoning people with mercury was bad, and actually published this in multiple newspaper articles. For example, he said that Russia's mercury was one of those discoveries which has contributed to the depopulation of the earth, and then said Rush has compared mercury to Samson from the Bible, and Cobbett thought that was accurate because Samson killed thousands, but Rush with his mercury has killed tens of thousands. Like, there was no doubt at the time this stuff was dangerous and poisonous. I mean, the man was putting it in the newspapers here, people. And in fact, so eminent was Dr. Rush, who that despite poisoning people with this stuff, resulting in lots of maiming and killing, he actually sued Cobbett for libel and won. Now that's some serious eminence there, people. Okay, that's the danger of eminence-based practice based because, well, somebody famous told us to do this 150 years ago. You never admit you were wrong. So here's the point. Historical practice that's based on no data whatsoever does not require perfect data to overturn. Any reasonable data suffice. Evidence-based medicine is preferred to eminence-based medicine, or as my mentor taught me, he was chair of medicine when I was a student and resident, data beat no data, and better data beat worse data. It's pretty simple, actually. If you prefer another luminary of medicine, Osler is said to have said, 50% of everything I'm teaching you is wrong. The only problem is I don't know which 50%. He wanted his students to go out into the world and evolve their practice as new things were learned, and understood that he didn't have all the answers. And that's what we should seek to achieve. So I'm going to show you a bunch of data. And if your temptation after you see those data is to say, well, those data are flawed, then I have to presume you're aware of some contrary data that are not flawed. Because if you aren't, then my people have a word for this. And that word is chutzpah. Because it takes some serious chutzpah to criticize 21 concordant randomized controlled trials when you have 0 supporting the opposing position. And with that as a framework introduction, let's start talking about these 3 diseases. We'll start with osteomyelitis, and just for fun, start with a little quiz. You could pop in the chat if you want, but no stress. I'm going to just tell you the answer in a minute anyway. What is the oldest known case of osteomyelitis? How far back in time must we go to find the oldest known case of osteomyelitis? There are people who will say to me, well, it's probably some mummies, right? There's probably some Egyptian mummies back there that had some Pott's disease from some TB, right? And it turns out you got to go back just a little bit further in time. Oh, dinosaurs, good guess. Okay, now, so here's the thing. It's all any osteo, tuberculous bacteria, any osteo, oldest of any kind, okay? Let me show you. The oldest known case of osteomyelitis that's ever been described was in this fella right here. Now, it turns out that this is a Dimetredon, and actually allegedly predated the dinosaurs. So this fella and all of their compatriots went extinct 250 million years ago. In the 1920s, a pathologist who clearly had way too much time on his hands was looking at the spinal shafts coming off the back of one of these creatures and noticed that there was a healing callus, and decided to section, I don't know how he got the fossil, section the fossil and microscopically diagnose the Dimetredon with osteomyelitis. And this is the oldest known case of osteomyelitis. And the fascinating thing about it is that the case of the Dimetredon with osteomyelitis underscores many of the modern problems we have in managing this disease. For example, the case went undiagnosed until rather late in the disease course when someone finally did a bone biopsy. The person who did the bone biopsy didn't send it off for cultures to help us target our therapy. How often does that happen in the modern era? And I will say that if treatment was administered at the time, it probably was given late in the disease course and didn't work very well. Although I will point out, if there was treatment given at the time, it probably was oral, because I don't think they had Dimetredon OPAC back then. Now, if you start with the case of the Dimetredon with osteomyelitis and you go forward in time, 250 million years, not very much changed, honestly, in the management of this disease until this paper was published right here in 1970. If you want to know why every physician on planet Earth, well, heck, in our soul, I've surveyed Neptune, they do the same thing there. The entire solar system, every physician says you got to give 4 to 6 weeks of IV antibiotics to treat chronic osteomyelitis. It all derives in the literature. You can trace the references back to this statement right here in this article published in the New England Journal of Medicine in 1970 by Dr. Waldvogel and colleagues. Now, this is going to create a precedent that's going to come up again. It turns out if you want to create an urban legend in which everyone believes with a religious fervor, with no questions allowed, all you really need to seem to do is to publish an opinion in the New England Journal of Medicine. So Dr. Waldvogel and his colleagues in 1970 said, if you want to successfully treat osteo, give 4 to 6 weeks of IV antibiotics. And everybody said, okay, that's what you have to do. And if you disagree with us, you're evil. And the urban legend was born. Okay, now here's the problem with this article. This was a retrospective uncontrolled case series, people. There was no control group. There was no intervention. They used IV penicillin and aminoglycosides for patients in the 1950s and 1960s. They didn't try orals. There was nothing else tried. This was an opinion published in the discussion of an uncontrolled case series. So when I show you the multiple concordant randomized control trials and you're like, well, those trials are flawed, this is what you're hitting me back with? Seriously? So about a decade ago, some colleagues got together, or Ben Lipsky and I got together to systematically review the literature on osteotherapy because we were frustrated by the state of knowledge of this disease. And one of the questions we asked is oral therapy. Can you actually deliver oral antibiotics to bone at levels that are adequate to inhibit microbial growth? And the answer is you can. There have been dozens and dozens and dozens of studies that have asked this question, often by looking at amputated body parts after infusion of antibiotic, or by looking at biopsy samples after infusion of antibiotic. And it turns out that you have options for gram negatives, anaerobes, and gram positives, all of which achieve adequate levels in bone with normal oral dosing to inhibit microbial growth, to exceed the target MICs of relevant pathogens. So just based on pharmacology, we could hypothesize that it should be possible to treat osteo orally. Are there clinical data that validate this? And the answer is, of course, there are. There are now more than 40 published observational studies looking at oral therapy for the treatment of osteomyelitis. Every single one of them shows clinical outcomes that are quite similar to those achieved historically with IV-only therapy. After 15 years of looking, I have never found a single study that drew the opposite conclusion, that showed that oral therapy fails at an alarming rate for chronic osteomyelitis. Now you say, okay, well, that's nice. Those are observational. They have biases. Don't you have any higher quality studies? And the answer is, yeah, I do. I actually have 9 randomized controlled trials, people. 9. Like, what's the magic number? Like, are you like, well, if you had 11, I believe you, but you only have 9 for sure. When is it just embarrassing that you're starting to pile on? Like, how many do you need? There are 9 randomized controlled trials that compared oral therapy to IV-only therapy. And all 9 of them showed that oral therapy was as effective in most cases with reduced adverse events, which means there are none that showed that IV was superior. Now, I don't have time to walk you through all 9 trials. The OVIVA trial is by far the most important because it is by far the largest. Now, when it was published, people were like, oh, we finally have a randomized controlled trial that answers this question. I was like, oh, you mean we finally have the 8th randomized controlled, because it's the 8th. Now, it's by far the most important. I'm not trying to undersell it, but just keep in mind, it was the 8th such trial, and there is now a 9th. This was 1,000 patients randomized, multi-centered, multiple sites of osteo, multiple organisms, multiple drug regimens used off a menu that the investigators could pick from. And across every analysis looked at, every population, every endpoint, everything, oral was no worse than intravenous. In fact, in the principal analyses conducted, if anything, oral looked better. The 95% confidence intervals favored oral, certainly was not worse. So skeptical was the New England Journal of Medicine, which, after all, was the journal that had created the mythology of IV-only therapy a half-century earlier, that they forced the authors to conduct a post-hoc, non-pre-planned, worst-case sensitivity analysis. They would not publish the paper unless the authors did this, in which they set all missing data in the oral arm to failure and all missing data in the IV arm to success. And even that analysis failed to establish the superiority of IV-only therapy. But you know what was different between oral and IV therapy in these patients? The rate of complications of a catheter, which was ninefold, people, more frequent in the IV-only arm than the oral arm, about which my commentary is duh. And you know what else was different? The investigators applied prospectively to all randomized patients patient satisfaction surveys. And patients randomized to oral therapy reported statistically significantly better mobility, self-care, activity, pain, discomfort, anxiety, and depression. It turns out patients don't like having large plastic tubing in their central veins for 6 weeks at a time, again, about which my commentary is duh. And of course, oral therapy was less expensive. Now, a few years ago now, it's probably 2 years ago or so, some colleagues got together to systematically review this literature. Here is your tabular summary of the 9 randomized controlled trials. This last trial, which came out of Australia, was actually designed as a 6 versus 12-week study. But in the 6-week arm, 95% of the therapy given was oral. It was almost all oral. In the 12-week arm, it was 6 weeks IV only, and then they allowed 6 weeks of oral transition after that. So if anything, that should have enhanced the cure rate in the 12-week arm, and obviously it was not successful in doing so. Here is your weighted average, oral versus IV. If you prefer more formal statistics, here is your random effects forest plot meta-analysis, with your summary statistic very clearly establishing that oral therapy is not worse than, or frankly different than, IV-only therapy in the treatment of this disease. And your funnel plot showing no evidence of publication bias. Now, in addition to those 9 randomized controlled trials, there are 18 other studies, 17 randomized controlled trials, and 1 pre-post quasi-experimental study in children. Totally distinct 18 other studies that compared oral to oral therapy. Almost all the therapy in both arms was oral. This was either because they were comparing short versus longer courses of therapy, or drug regimen A versus drug regimen B. And in all of these trials, the cure rates were in the same 80 to 85% success rate that you always see in trials of osteomyelitis, whether given orally or IV. These trials included every conceivable manifestation of osteomyelitis, including vertebral, diabetic foot, prosthetic joint, all the different types of pathogens you might encounter, with a whole variety of different antimicrobials used, amoxicillin, for example, being the most common studied for diabetic foot osteo. Collectively, these 18 studies, plus the 9 that compared oral to IV, feel like an incredibly robust data set, confirming unequivocally that oral therapy works for this disease. Frankly, I'm not sure what the debate is about anymore. The data are overwhelming. But that's not necessarily bacteremia and endocarditis. What's the deal with those? Well, I showed you the historical basis for the belief that you have to give IV for osteo. What's the basis for the belief that you have to do it for endocarditis? You can really trace in the literature that historical belief back to this study from 1943. This was the start of the myth, okay? Sulfa became available 5 to 6 years before the first use of penicillin. And the sulfonamides were the first miracle drugs, frankly. For many types of infections, they transformed the survival rate. So they were tried for endocarditis as well, and the experience was rather disappointing. So this was one of the first, and certainly was the largest case series looking at patients with endocarditis, 760 of them treated with sulfa, compared to about 2,500 treated pre-sulfa. And what they found was that before sulfa, endocarditis was nearly 100% fatal. Sulfa improved that a little bit to about a 4% survival rate. So you went from 100% mortality to 96% mortality, which is better, but nobody was impressed by this. You could sort of mathematically express this finding as 400% of a not good outcome is 400% of a not very good outcome. And in fact, other case series with sulfa had found similar results. When oral erythromycin and tetracycline were developed in the late 40s and early 50s, they were also attempted for endocarditis because IV therapy was inconvenient. And they did a little bit better. They got you to maybe a 20% success rate, but that was nowhere near as effective as IV penicillin was, which was achieving 75 to 85% success rates. And those were the data available to Dr. Max Finland, one of the giants of infectious diseases of the 20th century, when he wrote this review article in, guess which journal? The New England Journal of Medicine. And he said, quote, "Oral may sometimes work, but it probably usually doesn't, but we don't really know." This is it, people. If you trace the references back in the literature, why everyone believes that you have to use IV therapy for this disease, it's this quote right here in this article in 1954. So when I show you the randomized controlled trials, you're like, those trials have flaws. This is what you're hitting me back with. If he had just waited a couple years, oral penicillin D was hard to develop. It took a while. It became available after Finland published that review. The first published experience with oral penicillin was not that bad with endocarditis. 4 patients treated with endocarditis, 3 were cured. The one patient who failed was infected with, quote, micrococcus, which was later renamed Staph aureus. And in the paper, they say that strain of micrococcus was in fact resistant to penicillin in vitro. So obviously not surprising that it would fail therapy. So a couple of years ago, again, some colleagues got together to summarize the literature on endocarditis. And just again, looking at the PK, tetracycline and erythromycin have massive volumes of distribution. They are not bloodstream drugs. Why would you think that a drug that leaves the bloodstream and achieves low peak levels that are below the MICs of relevant pathogens would be effective agents to treat a high-grade bloodstream infection? These are tissue drugs. They're concentrated in tissues. Now, sulfanilamide achieves higher levels in blood, but it is a dreadfully ineffective antimicrobial agent. This is not trim sulfa, remember. The sulfa alone has very high MICs. So again, you cannot reliably exceed the target MIC of pathogens in blood with sulfanilamide. So you cannot use the failure of older antibiotics that don't achieve good levels in blood to say that oral antibiotics can't be used to treat bloodstream infections. Modern oral antibiotics do achieve levels in blood that are well in excess of the target MICs of relevant pathogens. You might hypothesize based on this that they could be used to successfully treat such infections. Are there clinical data that validate this? Yes. There are numerous observational studies of bacteremia that I don't have time to go into, all of which show oral therapy works. And there are now 10 published randomized controlled trials, people. 10. 7 with gram positives, 3 with gram negatives. In every one of these studies, oral therapy was at least non-inferior to IV. In 2 of the studies, oral therapy was statistically significantly better than IV-only therapy at curing these infections. The 11th study, by the way, the Sabato trial was presented at ECCMID a year ago, and it should be published anytime now, I would think. Soon we will have 11 published randomized controlled trials that draw the same conclusion. Oral therapy works. Here's the current 10 published studies in tabular format. You can see the drugs used, the bugs. You can see the weighted average cure of oral versus IV. Again, if you prefer more formal statistics, here's your random effects forest plot meta-analysis. Boy, I mean, it's pretty clear oral isn't worse. If anything, it looks better. Now, you can't say it's statistically better. It crosses the zero boundary just a smidge, but it sure doesn't look worse, does it? Not what you would have expected to find when you set out to ask this question. Well, what about endocarditis, which is a more complex form of bacteremia? Well, there's now, more than 15 observational studies showing that oral therapy is effective for this disease, including a wide variety of patients, mostly left-sided, many different organisms, including MRSA. And in all of these observational studies, oral therapy achieved similar cure rates as historical norms for IV. There are also now 2 case control studies and a new cohort study. So just quickly to go through the case control studies, this was the first one from France from about a decade ago. 19 patients were transitioned to oral therapy. And these patients were transitioned to oral therapy not because they were doing well, but because they had developed complications either from the drug or the IV itself, or in a couple of cases, because they were resistant to everything other than linezolid. You can see which patients were switched. There was mostly staph and a little strep, a wide variety of oral regimens used. None of the patients switched to oral therapy died, whereas a quarter of patients switched to IV therapy died. In the larger observational study, this is now more than 400 patients, more than 200 of whom got oral therapy, mostly left-sided disease, lots of prosthetics and devices, a fair amount of staph included, a variety of oral regimens. And again, here, they found that patients who got switched to oral therapy had statistically significantly lower death rate and relapse rate. Now, these are observational studies. They have confounding, but the first 2 at least provide some reassurance that oral therapy is not intrinsically going to lead to failure. The outcomes are quite good in observational studies. This is the most recent study, which just came out a couple months ago from our health system, looking at cases since 2019, mostly staph. And in fact, the oral arm had statistically significantly more MRSA than the IV arm. And there was no difference in survival, clinical cure, or relapse at 90 days or follow-up, or last follow-up in patients given oral therapy. We looked at the duration of IV lead-in. It was no relationship between the number of days of IV lead-in before transitioning to oral and outcomes, but there was a significant reduction in adverse event in patients who received oral therapy. So the observational data are aligned with the PK data. Are there randomized controlled trials? And the answer is, of course there are, right? That's why we're doing this talk. The first trial no one really remembers. It's from 30 years ago now. It was a small trial. It was all strep, half viridans, half bovis. Patients were randomized to IV only or transitioned to oral amoxicillin, and all patients were cured at up to 6 months of follow-up. It's not that hard to cure streptococcal endocarditis. The second randomized controlled trial is the Heldman study from Johns Hopkins. This was a study of patients, all of whom had Staph aureus endocarditis with a history of intravenous drug use. Patients who came to the ER with a history of injection drug use, who had a fever and a murmur or any other reason to suspect endocarditis, were randomized in the ER to oral versus IV therapy. There was no IV lead-in therapy here. Oral therapy was started up front as soon as there was a suspicion for endocarditis by randomization. It was a weird oral regimen. They did not have advanced generation quinolones at the time. So to protect the Cipro, they added rifampin. So that was the oral regimen used. They found no difference in clinical or microbiological cure in oral versus IV patients, but a massive increase in adverse events in the IV-only arm. Oral was much safer. Now, it's not a large study. They're mostly younger patients. mostly right-sided endocarditis because of the history of IV drug use. I will also point out that Cipro is not the drug you or I would use for staph. And I think that 300 BID of rifampin is not the correct dose based on pharmacology. We could debate whether it's 600 once a day, twice a day, or 900 a day, but 300 BID achieves much lower levels. And so I think both the Cipro and the wrong rifampin dosing, if anything, would have disadvantaged the oral arm. And then there's the big complaint about the study, which people love to hit me with, which is there wasn't very much MRSA in the study. It was mostly MSSA. Now let's just get this one out of the way because people hit me with this all the time. Right? This is a phantom menace. The lack of MRSA is a phantom menace. It's one of the most common complaints I hear, and it makes no sense. And here's why. Does anybody disagree with this statement? Does anybody here believe that IV Vanco is more effective for MRSA than beta-lactams are for MSSA? Because I've probably given this talk 50 times now, and no one's ever disagreed with this. We all believe beta-lactams for MSSA result in better outcomes than Vanco for MRSA, right? Nobody really disagrees with that. So if you accept that premise, then what you are left with is the mathematical transitive principle. If A equals B and B equals C, then A equals C. Okay? If IV therapy with beta-lactams for MSSA is at least as effective as Vanco for MRSA, and you show that oral therapy is as effective as the more effective beta-lactams for MSSA, it must be at least as effective as Vanco for MRSA, right? Notice you could not go the other direction. If the data had shown oral therapy was as effective as Vanco for MRSA, none of us, including me, would feel comfortable saying, yes, that means it's as effective as beta-lactams for MSSA, but that's not the direction of the data. This complaint is the complaint that people issue when they don't want to let go of their historical anchor bias that IV is better. They're grasping at straws and they're reaching for anything they can point to that those data are flawed. And I'm like, okay, then that means that your case series from 1943 are not flawed, right? Because you have no other data that disagrees with this. Now, before we get to the last randomized control trial, the largest, it's worth mentioning this quasi-experimental study. It does have, I think, to me, some importance in terms of the role of Bacterem. But I will point out for full disclosure that the senior and corresponding author is Didier Raoult. You can do with that information whatever you think best in interpreting the results of the study. To my knowledge, this paper has not been retracted and no one has raised concerns about the data in the paper. But Didier Raoult is a source of controversy, and so you need to factor that in when you consider the data. This was a pre-post study. In January of 2012, the center in France put in place an IV to oral conversion protocol for staph endocarditis. So all 341 patients here were staph endocarditis. Starting in January of 2012, everyone got a week of IV lead-in therapy with dual Bactrim plus clindamycin, which is a weird regimen, all of us would say, and then got switched after 1 week to 5 weeks of oral high-dose Bactrim. The investigators then went back and looked at 170 consecutive control patients from the prior decade who had been given standard of care IV-only therapy and compared their outcomes to 171 consecutive patients after the conversion to this new protocol. This was mostly left-sided disease. There were lots of prosthetic valves and devices, and there was MRSA. Interestingly, the investigators reported that patients given the oral regimen had statistically significant reductions in both death and relapses. Now note the absolute change in mortality here. This is an 11% absolute difference in mortality. That number is going to come up again in a minute. That brings us to the POET study. 400 patients randomized, multi-centered, mostly left-sided disease, lots of prosthetic valves and devices, and a menu of drug regimens that you could pick from. In the original publication, at 6 months of follow-up, There was no significant difference in oral versus IV therapy, right? So the original study absolutely supports the efficacy of oral therapy. If anything, numerically, oral looked a little better, but it wasn't statistically significantly different. The authors have now gone back and published 3.5 and now even 5-year follow-up data. By 3.5 years of follow-up, patients who had been randomized 3.5 years earlier to oral therapy had statistically significantly better treatment failure and lower mortality rates. And look at the magnitude of the difference in mortality, 11%, just as in the quasi-experimental study. This is not what you probably would have expected from an oral versus IV study of this disease. We now have 20 observational, a quasi-experimental, and 3 randomized controlled trials for endocarditis, all of which show that oral therapy works. In the largest such studies, oral therapy was not only not worse, it was superior to IV-only therapy. Here are the 4 prospective studies shown in tabular format with your quasi-experimental study in italics. You can see whether you include the quasi-experimental study or not, it really doesn't change the outcome of the weighted average. Here is your forest plot, random effects meta-analysis with the quasi-experimental study showing statistically significantly better outcomes with oral therapy. You don't like the quasi-experimental study, let's take it out, that's no problem. It doesn't really change the conclusion other than it widens out the confidence interval, so you can no longer declare statistical superiority, but you certainly can say that oral therapy was not inferior. Are there any contrary data? Now, I've given this talk in numerous countries and would be delighted to, if somebody could, give me the Afrikaans version of this, I'd be delighted to add it to the slide. Doesn't matter what language you say the word in, the answer is none. There are no contrary data. In fact, I am a space alien from another solar system, and as such have decided to give you even intergalactic languages. And even in intergalactic languages, the answer is none. Okay, thank you very much. Nix, that's going on the slide. Perfect, thank you. In summary, all of the available controlled studies, that's 21 randomized controlled trials, show that oral therapy is safe and effective for these 3 diseases. There are no published contrary studies. Does this mean you can use any drug you want? Well, of course not. You want to use a bioavailable agent with published efficacy data. I certainly wouldn't use sulfanilamide for endocarditis, right? And then people will say to me, are you really suggesting that oral therapy is more effective than endocarditis? Are you really crazily suggesting that? And my answer is, I don't actually know. There's certainly a strong suggestion that it might be, but personally, I think we would need a second large randomized controlled trial to confirm or draw the conclusion of superiority. What I am convinced of is that it's not worse. Whether it's superior, I would want a second trial. If it is superior, the question is why? Why would that be? And I don't know. I've heard multiple hypotheses, but I'm just going to refer you to the poet Kaplan-Meier curves. Interestingly, in the Kaplan-Meier curves from the poet study, the survival begins to diverge during the first 4 to 6 weeks of therapy. During active therapy, the Kaplan-Meier survival curves had already begun to diverge. But the magnitude of the difference continued to widen over the 6 months, all the way out to 5 years. These curves were still diverging. What could the explanation be that 5 years ago, you were given a treatment that was different, and so your survival is still widening out 5 years later? I don't know the answer, but it makes me wonder if this is about harm avoidance. Is this because more people got DVTs or central venous stenosis, and those things haunted them for years thereafter? I don't know. To me, this is a fascinating source of investigation for the future. And then there's this one. But guidelines. Okay, look, I don't care about no stinking guidelines. Okay, the guidelines are out of date. The guidelines are written by people that are embarrassed that they've gotten this so wrong. So I'm not going to wait for the guidelines to change and catch up. A, use the data, not the guidelines. B, this is why we invented wiki guidelines, so that people who actually practice medicine can actually interpret the data rather than leaving opinions that are not based on data that set standards of care. The osteomyelitis guideline is published and does clearly state a clear recommendation that oral therapy is safe and effective for this disease. The endocarditis guideline, which Tom Boyles helped us draft, is submitted for publication and hopefully will be out within the next 6 months. In our system, we've given some guidance to our practitioners, expected practices, for how to select patients who are eligible for oral therapy. And we have suggested that you can switch to oral when these 5 things are true, all 5. The patient is clinically stable. If source control procedure is needed, you have achieved it, because it makes no sense to make someone put them on oral therapy and then make them NPO for the procedure, and then they can't take their oral therapy. We have suggested, not based so much on data, that if the patient is persistently bacteremic, don't switch to oral. The reason for this is the number one reason they are persistently bacteremia is you need source control, right? So we don't want people rushed home on orals if they needed a drainage or a surgery that they didn't get. You have a published regimen that covers the target bacteria. The gut is working, and there's no psychosocial reasons to prefer IV, whether this is adherence related or procuring housing by justifying a skilled nursing need. When all 5 of these things are true, you switch to oral therapy. Whenever that is, if that's day 2, it's day 2. If it's day 1, it's day 1. If it's day 21, it's day 21. We use clinical criteria, not an arbitrary duration of number of days of IV lead-in. We've given our docs some guidance over which drugs, covering which bugs, at what doses, were in which published trials of efficacy, and some additional text so they can help pick the right drug for their patients. And then finally, I'm just going to close with this last slide. In 1900, Dr. Osler was frustrated with the medical community. He was frustrated that doctors did not evolve their practice based on new data. And he pointed out that being conservative and being an old fogey are 2 completely different things. The motto of the first is prove all things and hold fast that which is good. And of the other, prove nothing, just hold fast that which is old. We need to stop doing the latter and start doing the former. With that, thank you very much for your attention. I'll stop.
Thank you so much. I can't tell you how many messages I'm getting on WhatsApp and on private chat expressing delight at the talk. So you've converted a whole bunch more people, I think, and most importantly, expanded decreased the chances that anyone will ever think you put people into comas giving talks, because that was a fantastic talk. So thank you. I'm just going to go through a couple of the questions if you've got a moment, Brad, before you have to go. One of them was about, well, actually, your sort of local experience. Did you find a lot of pushback at your own medical center, or were you able to convince people kind of when confronted with the force of evidence pretty quickly? Have you found the conversion quick?
No, it wasn't quick. It took time. Obviously, I have a lot more influence at my own hospital. So I would say a year or 2 of nagging, giving this kind of a talk, showing people the data. People here are now fully converted. There is no pushback internally amongst any, even our cardiovascular surgeons, cardiothoracic surgeons. Oh, yeah, didn't know that. Cool, thanks for showing me. Our sister hospitals has been a harder fight. That's why we created the expected practice, because it's system-wide. Even they are now starting to get on board, but it's going to take, it takes 15 years to get doctors to change their practice. It's just a constant struggle. We just have to keep talking about it.
There's a question in the chat from Nilesh Govender, one of our mycologists, about IV versus oral for fungal infections. And I know there's obviously less data, but do you think it's going to go the similar way with highly bioavailable, say, azoles or other options like that with fluconazole?
Actually, I kind of think that in most cases, people are already there. I think people are very comfortable with azoles, fluconazole for crypto, for example, voriconazole or isavuconazole for aspergillus. I think for whatever reason, that's already sort of been a more comfortable baked-in model of practice in the fungal space.
Yeah. There's a question in the chat about specific oral beta-lactams. I know obviously you won't have you've drawn up these tables too, so that we can refer to as well. But things like flucloxacillin for Staph aureus osteitis. I mean, I guess the concern there may be bioavailability with that.
Yeah, so that's a great question. There's no data that I'm aware of. Well, I should be careful. There's no prospective data. I'm not sure. I'd have to go back and look at those 40 observational studies to see if fluclox is in there. Generally speaking, I tend to avoid most of the oral beta-lactams, not because I'm convinced they won't work, but because I prefer to use things that have been published. Now, amoxiclav has been published in the setting of diabetic foot, and it works very well as IV therapy, which suggests that there are some beta-lactams that certainly will work in bone. I think I'm increasingly comfortable with cefadroxil. I have very little experience with fluclox, and it's a 4 times a day drug. There I start to worry, is someone actually going to take the 4 times a day drug for a week? So it's not that I think you can't use it. It's just that my own personal practice is to try to use things that have been published more often than things that have not yet been.
Lots of questions in the chat about specific instances. I mean, I guess one really good resource, I mean, I can say it if you can't, is to go to your website. So bradspellberg.com, right? Which you collect this data on there, which is a really fantastic resource for those who are looking for it. I mean, one of the questions that came up was meningitis. I mean, that's one of the harder ones to push, but I guess also just bioavailability versus not, rather than intravenous versus oral.
Bioavailability and tissue penetration. Quinolones and Bacterem get into the CNS exceptionally well. We know this. There are, in fact, diseases we use like listeria, like toxo, where we know that they work. And when there's PK studies that show they get in. So I use the same 5 clinical criteria. If someone is doing well, I know I can cover their bug, their gut is working, there's no source control need, all that stuff. If that applies, I'm very comfortable using oral therapy.
All right, I'm going to just pick one last question just before you have to go. Well, there's one on the bottom about Pseudomonas again. So presumably same deal, right? With Pseudomonas when we have quinolones.
Yeah, I mean, Pseudomonas is hard because there's not many oral options, but quinolones are perfectly fine. We could talk about osteo in a moment, but generally speaking, quinolones, if it's susceptible, quinolones are reasonable. There are phosphomycin data for Pseudomonas. Phospho has good activity against Pseudomonas. I actually have done that in a pinch. For osteo, the relapse rate of Pseudomonas infection is astoundingly high. It's like 60 to 70% at 3 years of follow-up. I suspect, but do not know, that's because it has a high propensity to develop biofilm-associated non-replicating persisters. And so I will not infrequently add rifampin. So quinolone plus rifampin or phosphomycin plus rifampin, on the theory that rifampin is the one drug that kills the non-replicating persisters. Now, I don't have great data. There are some case series for Pseudomonas osteo for rifampin, but that's my own practice. I think if you have an oral agent that covers it, it's not unreasonable to do.
Well, thank you very, very much again. And again, just so everyone in the audience appreciates, I mean, this is just coming up on 7 a.m. for you. So we really appreciate you taking time out of your day. And thank you so much for giving so freely of your time and expertise, really. Like I said, you have a lot of fans this part of the world in terms of practice changing, the stuff you've been doing. So keep doing it, please. And we'll look forward to seeing and hearing more from you and other like-minded people. Thank you very, very much.
Thank you very much, Dr. Nell. And thanks everybody for joining. Thanks for the invite.